Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez, and I'm your host for another important health topic. November is Pancreatic Cancer Awareness. We've all heard about pancreatic cancer. We know pancreatic cancer is not good. But obviously there are risk factors, there's hope, there's treatment. And so to bring awareness about pancreatic cancer, to bring education and learn about pancreatic cancer, I brought a hepatobiliary surgeon. It's a pancreatic surgeon, a surgeon who operates on the pancreas and all those structures around the pancreas. Domenech Asbun. Welcome.
Thank you. Pleasure to be here.
All righty. So Domenech, first explain to us, what is this hepatobiliary surgeon? Very long term, and what does that mean? I know, as I mentioned, you operate on the pancreas, but what do you do?
Right. It's quite a mouthful. So if you break it up, hepatopancreatobiliary is basically talking about three organ systems. We're talking about hepato, which is liver, pancreato, which is pancreas, and biliary, which is the bile ducts. And I'm sure a lot of the listeners are aware of the anatomy roughly, but if I were to try to summarize, the liver, one of the many things it does is it makes bile that goes down these tubes, these bile ducts, into the intestines. Now the end of that bile duct goes through the pancreas, which is another important organ, and the pancreas has its own duct or tube that also plugs into the intestines in the same area. So these three organs, really two organs, and then the ducts from the liver are very interconnected. And a lot of times when you have problems with one, it can lead to problems with the other. And that's why the surgical specialists that treat these tend to be very familiar with all three of those areas, because you most of the time are kind of balancing out how one intervention will affect another organ.
All right, so today we're going to focus on the pancreas, but you'll tell us that obviously the bile ducts will be affected by pancreatic cancer as well. We'll talk about that. So first, what is the pancreas? Where is the pancreas? What does the pancreas do for us?
So the pancreas, a lot of people that hear about the pancreas hear about it through the lens of diabetes and the effect that it can have on controlling your blood sugar. Now, the pancreas is an organ that creates hormones, and it also creates enzymes. Now, enzymes are they're these proteins that are put into a juice essentially that gets excreted into the intestines that helps you digest food, particularly fatty food. The hormones go into the blood vessels near the pancreas and then to your whole body, and they help regulate a lot of different metabolic systems in your body, including the control of sugar. The pancreas makes a lot more hormones than just insulin, but that's one of the famous ones, the important ones. And these, what the pancreas does essentially is most of it is related to digestion, and it's in an area of the body that's a little difficult to find. It's in what we call the retroperitoneum. So if you imagine your abdomen, your belly as a balloon, and inside the balloon you have all these organs. Right towards the back of it, kind of tucked away under some fat and behind a lot of other organs, is the pancreas. And so it's connected to the intestines. It's connected to the bile duct, or the bile duct goes through it, and it's surrounded by a lot of other important organs. And so as we'll discuss more, some of the difficulties in treating the pancreas have to do with where it is anatomically. It's also, on top of all that, some very, very important blood vessels run directly behind it and adjacent to one specific portion of it. So that makes the surgeries more complex and the treatments more complex.
All right, so we know what it is now. Pancreatic cancer. How common is it? What is it? How do people get pancreatic cancer? We know breast cancer is genetic. We know skin cancer because of the sun, lung cancer because of smoking.
Yeah, so it's a great question. And, all these cancers are really, they're caused by usually a combination of two things. One is the genetics, and two is what external factors are affecting those cells. So if we take a step back, when we're talking about cancer, it sounds like we're talking about something that's invading your body, right? Like a bacteria or a virus, something that's foreign. The reality of it is cancer starts within us. Our body physically is nothing but cells, and what a cancer is those cells that are usually helping us, that are part of our body, they get weird. I tell patients they turn sort of into zombie cells, and they start making copies of themselves. So one zombie cell becomes 2, 4, 8, etc., and they build up until you get millions and millions of these cells. Now, depending on where that cell is, that's how we name and categorize cancers. So a pancreas cancer is a cancer that starts in the pancreas. Specifically, when we're talking about pancreas cancer, most of the time we're talking about the type that comes from the tube that lines the pancreas duct. And so going back to this idea of both genetics and external factors, both of those usually come into play, sometimes more one, sometimes more the other, to cause the changes in these pancreatic cells that used to be normal, but then they become weird, right? They become these zombie cells. So things that can cause, apart from having genes that put you at a higher risk, external factors that can cause pancreas cancers to develop a lot of these are things that people have already heard of. So cigarette smoke, or just nicotine use in general, but especially smoking cigarettes. Anytime you have a lot of inflammation of the cells, so a lot of irritation of the cells over time, that can cause the cells to turn into cancer. So something like pancreatitis, which is an inflammation of the pancreas, can lead to cancer. The pancreatitis is usually caused by a lot of alcohol. People that drink alcohol for a long time can get chronic pancreatitis, so pancreatitis over a long time. Sometimes you can have people that have some genetic predisposition to getting pancreatitis. And more recently, we've been seeing, even though it's not as strongly correlated, but there seems to be an association between obesity and eventually a higher risk of pancreatic cancer. There's a long list. Another important one is age. Just like anything, the older we get, the more likely that our cells will have some type of mutation that causes them to turn into cancer. So it's, unfortunately, it's a combination of these, but sometimes we do see patients that don't have any of these risk factors that show up with pancreas cancer. There's still a lot that we need to learn.
It's funny how obesity is just over and over and over, whether it be obesity causing diabetes, high blood pressure, obstructive sleep apnea, just puts you at risk for so many other medical problems.
It really is. Yeah, it really is. It's, obesity, and you know this well, you know this better than I do. It causes a inflammatory state in your body, right? It's sort of like your body's already a little bit irritated, you could say. One of the thoughts is that because the pancreas gets replaced by fat in many cases, that causes a little bit of irritation and inflammation. But yeah, unfortunately, obesity has a lot of health effects.
All right, so symptoms. So we're learning about pancreatic cancer. We want to obviously catch any cancer early, and this is very important to catch early. What are the symptoms? What do you feel when what do patients come in complaining about?
The typical textbook symptom is what we call painless jaundice. So jaundice means you're looking yellow, your eyes are yellow, your skin is yellow. And this is from a blockage in the bile duct. Remember, the bile gets drained from the liver into a tube that goes through the pancreas into the intestines. The pancreas part of it will sometimes get narrow because there's a cancer pushing on that tube, and this is in what's called the head of the pancreas. That causes people to be yellow. However, usually there's no pain associated with it. There are other causes of jaundice. Sometimes it can be from an irritation of the liver called hepatitis, and that will make you look yellow, but that's usually associated with some type of abdominal pain or discomfort. For pancreas, the typical symptom is painless jaundice. Now, there are a lot of other symptoms that are much less specific that sometimes patients will show up with. So weight loss, poor appetite, poor energy, vague abdominal pain, especially if it's towards the top. These are things that we do see in our patients. It's important to know that most people that have abdominal pain and have these vague symptoms don't have pancreas cancer. Exactly. Yeah, exactly. But those are the things that we see.
Yeah. Now everybody with abdominal pain is going to rush.
Don't worry. Yeah. I mean, I'm happy to talk to them, but they're probably fine. Exactly.
All right. So somebody has this painless jaundice. They come in, they turn yellow. They don't have any abdominal pain. What's the testing that gets done for them? So
usually these people come to the ER, for example, and usually what will get ordered is a CT scan. It's a good way to look at the belly. Sometimes we'll go straight to an MRI. For our personal practice, we like to use MRIs more than CT scans once we know we're dealing with the pancreas. But either way, what you're doing is you're getting a good idea of what it looks like inside, right? You get blood work that will prove that your bilirubin is high. That's what happens when there's a blockage in the bile duct. We can get blood work to test for what are called tumor markers. So it's essentially there are certain levels in your blood that will go up if there are cancers. It's not diagnostic. So to really get the diagnosis of cancer, you usually need a piece of the tissue. That's a biopsy. That's we can talk later about how that's done. But the tumor markers help correlate a little bit. If you see something very high that should be normal, sometimes it raises your red flags.
All right, so your patient has the MRI, there's a mass there, there's a concern of pancreatic cancer. So how did they make that diagnosis?
So basically there's three things when you're dealing with any cancer. Kind of a quick way to describe this is you want to name it, you want to stage it, and then you want to figure out how you're going to treat it. So naming it is essentially what I was talking about with the biopsy. For pancreas cancers in particular, we pretty much always need a biopsy to be able to prove that it's pancreas cancer. This is most often done through what's called an endoscopic ultrasound. So just like for other issues in the stomach, people will get an endoscopy. It's a camera that goes down your throat into your stomach. Advanced gastroenterologists will be able to use a special scope that has an ultrasound probe, and with the ultrasound they can see where the mass is in the pancreas, and with that same ultrasound endoscopy they can pass a needle into the pancreas mass and then take little cells. Those cells get sent to the pathologist who looks at them under a microscope. Usually takes about a week or so, and then they can, based on how strange those cells look and different stains and other studies that they do, they can confirm, yes, this is pancreas cancer, and specifically what type. If it is a cancer from the pancreas, like I said, the cells from the duct, what we call adenocarcinoma of the pancreas, is the most common, and that's usually what they'll find on the biopsy results.
All right, so everybody who has cancer always wants to have surgery. And doctor, get this out of me immediately today. I want it out this afternoon,
Yeah.
You're going to explain to us what the treatment protocol is and how a lot of pancreatic cancer can't be operated on, right?
Agreed.
I mean, so explain to us how, what is treatment? Now I have the biopsy, I have pancreatic cancer, do I have surgery immediately? Do I have chemo? Can I have neither?
Right. Yeah, it's a really good question, and the goal is to be able to get people to surgery. That's the ideal situation, because the reality as of right now, we don't expect a full cure without surgery. Now, the unfortunate truth is that only about 15% of people, that's 15% of people with pancreas cancer, will get to consider surgery. Wow. And what that tells you is that this is an aggressive disease. Now, for a lot of reasons, the pancreas cancer, when it's diagnosed, is sometimes what we call inoperable. The two main things we look at to see whether or not we can consider surgery are, one, has there been metastasis? Metastasis is where the cells that started in one area, let's say in the head of the pancreas, they got so weird and deranged that they break off and they travel somewhere else, most commonly the liver, and then they get stuck there and they start making copies in the liver. This tells you that the disease in the pancreas has basically, the cat's out of the bag, and there are cells in many places. Pancreas cancer is one that spreads early, unfortunately, and so when we see that there's been metastasis, we know that even if we were to cut out everything we can see, there are small microscopic cells somewhere else in the body that will continue to grow. The other thing is if we can physically cut out the tumor without leaving behind cells. And as I mentioned, there's some important blood vessels around the pancreas. Most commonly, we look at the relationship between the tumor, which is the ball of cancer cells, and those blood vessels. And if we don't think that we can surgically separate the tumor from the blood vessels, we don't do a surgery. And what this is getting at is that if you leave cells behind, either because there's metastasis or because it's grown around the important blood vessels, doing a surgery will not help. This has been studied. Patients do the same as if they didn't have surgery, or sometimes even worse, because the surgeries are big surgeries, high risk of complications, and a big operation will suppress your immune system and cause other problems that can actually give the cells that are left behind a chance to grow faster. So unfortunately, if we don't think we can get everything out, we don't operate, and we look for other alternatives.
Yeah, so then you can operate on 85% of them. So what do they get?
Right.
Does everybody get chemo? Is there anything else?
Yes. So, I mentioned that without surgery, you can't expect a cure. Now, that's unfortunately true, but there are a lot of things that we can do that can still help. Okay, we can still see a benefit in terms of survival. And with some of the newer things, even though we don't have as much data, we're seeing many more years than we would have expected. Mm-hmm. So the first thing, sort of the foundation of treatment of pancreas cancer, even if you're going to get surgery, is chemotherapy. Surgery is something local, right? You're cutting out the mass. Chemotherapy is something what we call systemic, something that goes to your entire body. The chemotherapy will kill any of these little cells that are floating around, and this is how we can start getting control, sort of reining in any cells that may have floated out. Now, if you're not going to get surgery, you can still help by giving chemotherapy and killing these cancer cells. Unfortunately, none of our chemotherapy is so good that we can completely treat it with chemo, but it does help. Now, most of the times you start with the chemotherapy, and once you've seen that you've been able to control a little bit, if you can't operate, then you say, okay, well, what other things can we do to try to get rid of that big ball of cells? Of cancer cells, or the mass, or the tumor. We are looking at a couple different technologies where I'm practicing at Miami Cancer Institute. Our two main options are what's called IRE, reversible electroporation, or nanoknife is the trade name, or radiation. The IRE is something where two probes are put around the tumor, and the tumor is essentially electrocuted. Mm-hmm. An electrical current runs between the probes, and it causes the cells to die off. radiation is something that is done externally. There's a machine that will shoot high-powered X-rays, essentially, will concentrate them on the area where the tumor is and some of the surrounding lymph nodes, and will burn them. We now have a machine called MR-Linac machine, which is really, it's not available in too many places in the world, and it's really giving us some impressive results because it is based on using an MRI, which can get real-time images, and it can concentrate the dose of radiation much higher than some of the older standard radiation. And so with those two, the combination of those things, we have a lot of options for our patients to see what we can really do to help them out.
Wow, that's incredible. And that electrical treatment, that electrocution, we've seen good results with that?
We have. The data is still, I'd say, somewhat preliminary, and we're careful about patient selection. It seems that it's best when patients' tumors are less than 3 centimeters. That's the protocol that we use at our institution, and it's based on some of the studies and the trials that have been done for the IRE, the electrocution. But yeah, it's giving us some interesting results. It's a great tool.
And then you didn't talk about relatives. Is there a genetic? We talked a little bit about genetic, but if my father died of pancreatic cancer, we know colon cancer. If you had a first-degree relative, you got to be screened with colon cancer. Pancreatic cancer, relatives, father, mother, aunt with pancreatic cancer, is that a concern?
Very much so. So anytime you have a first-degree relative, so like you're saying, a brother, a sister, mother, father, etc., that has a cancer, especially something like pancreas cancer, it puts you at a higher risk just because we know there's an association with genes. Usually what will happen is if someone gets diagnosed with cancer, especially if it's not who you expect, so if it's someone that's young, for example, or someone that has a lot of first-degree relatives, you'll do some genetic testing and see if they have a gene mutation that we know about. So these genes are passed down along families, and they're just like with breast cancer. People hear about the BRCA gene, BRCA1 and 2. There are certain genes that are associated with pancreas cancer, including, by the way, the BRCA gene. And so if we identify those genes in someone, we say, okay, you definitely have a higher risk of getting pancreas cancer. And we put these people in a small minority of patients, which we might actually recommend screening. Screening meaning you're looking for something even if there's no signs of it. So that's why you get yearly colonoscopies, right, or mammograms. A screening MRI or even an endoscopic ultrasound is usually what we would do more or less on a yearly basis for patients that are at this much of an increased risk of cancer, pancreatic cancer, based on their genetic predisposition. If you only have a first-degree relatives, but you don't have any of those known genes, then the guidelines aren't as strong to be able to suggest screening, but it's part of the conversation you have with your physician, and you always have in the back of your mind an understanding of the fact that you are at a higher risk.
So definitely we've heard obesity, smoking, first-degree relative. Okay, doc, they found some pancreatic cysts. Doctor found some cysts in my pancreas. He says it's no big deal. Is it a big deal?
Very good question. So cysts are another disease entity, and just like a lot of things, when I'm saying tumor or mass, I'm saying it's a thing, right? If I say it's a thing in my operative note, it doesn't sound as fancy as if I say, oh, there's a lesion in the pancreas. But essentially, these are words that are not very specific. When I'm saying cyst, what I'm saying is there's a fluid-filled area. It's an area of fluid within the pancreas, and you have cysts in the liver and the kidneys and other places as well.
Breast, they have cysts everywhere,
exactly,
right?
Yeah, well, it's a very generic term for something that is filled with fluid. So in the pancreas, when you see a pancreatic cyst, there's a list of differential diagnoses of possibilities of what this could be. Some of these are completely benign, meaning they don't cause any issues, they don't turn into cancer, we ignore them. Other ones we know are caused by injury to the pancreas, so something, for example, that we'd call a pseudocyst, and those we expect to go away very often. We don't have to do anything about them. And then we have another bucket of pancreatic cysts, or what we call pre-malignant cysts. So they're cysts that may not be cancerous now, but we know they're associated with what's called a degeneration to malignancy. So the cells around the cyst can turn into cancer cells down the line. And so this opens the door for a whole other field of study, which is what do we do with these cysts that we know could turn into cancer, but they're not cancer yet. The incidence of them turning into cancer is not that high. So a lot of people have these pancreatic cysts and nothing happens, and they have them their whole lives. A lot of times these are diagnosed when people are in their 60s, 70s, 80s because they're getting more CTs or MRIs. And so there's characteristics that we look at to see how dangerous does this cyst look. Does it look like it's turning into cancer, or does it look benign? So things like the size, things like whether it's just a nice clean round cyst, or whether it has weird parts of the wall, whether it's causing pancreatitis, whether it's involving the main main pancreatic duct or some of the branches off it. There are a lot of different things that we look at to evaluate how risky it is. And now one of the newer things we're checking are what's called a molecular analysis of the fluid. So through the same endoscopic ultrasound, we get a sample of the fluid and we analyze basically the genetics. We analyze for the cells in that fluid and see if there are certain genetic mutations that are associated with turning into cancer. And in those patients, we tend to worry a little more, even though it's a little bit of a newer way of evaluating these. That does help guide our management.
So actually, the take-home message is, if you have a cyst, it has to be evaluated and checked by an expert to determine whether you have like a cyst that's going to go away or a cyst that could be pre-malignant.
Exactly.
Right. So that's not something you're going to determine, or even a primary doctor is going to know this. So you need to see a specialist like you.
Exactly. You want to see a specialist. There are a lot of nuances, and it's important to get the appropriate follow-up. You don't want to completely blow this off if someone tells you go see somebody, but most often it's not going to turn into a problem.
Okay, good. And then the last pancreatic question I want to ask is Ozempic. There's so much use about Ozempic, and there's, questions about whether Ozempic, we know that Ozempic causes inflammation of the pancreas, right? There's pancreatitis, but can it cause pancreatic cancer? Talk to us.
Good question. And a lot of people ask me this. There's no evidence to show that Ozempic causes pancreatic cancer or any of these newer oral weight loss medications. Now, you're entirely right. They do cause pancreatitis. And we know that pancreatitis over many, many years can cause cancer, but it's usually a very severe pancreatitis. And as of right now, we haven't been able to make the link scientifically between saying, okay, you take Ozempic and okay, you're going to get pancreas cancer. Most of the times, if patients are getting pancreatitis from the Ozempic, you stop taking Ozempic and that's it, right? You're not going to get pancreatitis for 10 years, So as of right now, and this has been studied, there are no links between Ozempic or any of those other medications and pancreatitis. And pancreas cancer. Pancreas
cancer. All right, so we've learned about pancreas cancer, awareness, painless jaundice if you're turning yellow, if you have a family member, pancreatic cysts, get some evaluation. So that's what I've understood from pancreatic cancer. Quickly, in the last few minutes since I have you here, I want to touch upon another important topic. It's obviously something close to home. My mother-in-law died of gastric cancer, stomach cancer.
Sorry to hear that.
So talk to us in a few minutes. Gastric cancer, stomach cancer. Everybody thinks your stomach is your whole abdomen, but the stomach is one particular organ.
Right.
What is gastric cancer?
So basically, I'll try not to talk too much. I know I'm good at talking a lot.
No, but you've explained everything clearly.
Okay.
So
awesome.
we've learned, but we obviously want to learn a little bit about gastric cancer as well.
So your stomach, like you said, it's basically a bag within your belly, right? Your abdomen is really everything. The stomach is the first little bag where the food goes after you swallow it, and it goes down your esophagus. That's a tube. And so from there, and from the bag, from the stomach goes the intestines. Stomach cancer is less deadly than pancreatic cancer. It can be, of course, very dangerous if it's not treated well. I'm sorry to hear about your mother-in-law. That's, it's one of the unfortunate problems with this cancer is that it can take someone's life. And just like with pancreas cancer and really a lot of the other types of cancers, when you have a lot of inflammation of the stomach, it puts you at a high risk of getting pancreas cancer. So if you have infection with something called H. pylori, it's a bacteria that causes ulcers, chronic inflammation of that can lead to gastric cancer. If you have chronic ulcerations from reflux, that can lead to gastric cancer or esophageal cancer. They're connected. Anytime you have these issues where you're getting a lot of injury to the stomach over a long time, you can get gastric cancer. There are genetic conditions, just like we were discussing pancreas cancer, that put you at a higher risk of gastric cancer. Some where it's so high that you might even operate on a patient, take out their stomach just because they have that genetic mutation. Even though it's not common that we see that, but it exists. So having first degree relatives with a history of this, especially if it's atypical, if they're young, if it's happened to multiple relatives, should put patients at kind of on red alert to make sure they don't have any of these mutations.
Yeah, that's why my wife's getting her endoscopy now in a couple of weeks again, because we're checking her for sure.
Yeah. You're better safe than sorry. Exactly.
All right. So what are the symptoms? What are the symptoms of gastric cancer?
So usually they're similar to pancreas cancer. A lot of them can be nondescript. So abdominal pain, problems eating. They're usually associated with weight loss because patients over time will have issues where they can't swallow. Sometimes you get a lot of vomiting if the stomach cancer is starting to block the stomach. A lot of times not fully blocking it, but it is causing enough issues with digestion that people people are losing weight. If the stomach cancer has spread to other organs, sometimes people will feel lymph nodes in certain areas, bump somewhere, etc. These, just like pancreas cancer, tend to be in the same category as not super specific, but worth checking out if you're having these, especially over a long period of time. And
obviously, as you mentioned already, the endoscopy is the way that we do it, right?
Exactly.
Should everybody be getting endoscopies? I know, in our part of the world, in the U.S., it's not standard, but in the Far East, gastric cancer is more common.
Much more common, yeah,
right?
exactly.
And so it's standard of care in the East, but on the Western world, it's not.
It's not, correct. You're entirely right. So in the West, the recommendations to give screening anything, right? Colorectal, so colonoscopies or mammograms or whatever, it's based on how common does this happen in a population. So in the US, there are a lot of different organizations that look at how common something happens. It's not feasible to recommend that everybody gets screened for every type of cancer always, because when you only have 3% of the population that's going to get it, you're subjecting 97% of the population to these screening exams, which carry their own risk, even though it's low. So in the West, we have a lower incidence of gastric cancer than they do, for example, in Japan or China or in certain countries like Costa Rica or Chile. For whatever reason, they have a much higher incidence of gastric cancer, and so screening is much more common there. In the US, it's not indicated, but if you do have symptoms, very often one of the first steps, even if they're vague symptoms, a lot of reflux or weight loss or indigestion even, is a primary care doctor will refer to a gastroenterologist for an endoscopy, which is a great way to just check everything on the inside and make sure there's nothing going on.
All right, so somebody does an endoscopy, they get a gastric cancer, and what is the treatment of gastric cancer? I have been around long enough that it was always surgery first, but things have changed.
Right. There's one important trial. So this is, when we're coming up with treatment decisions, people test these things out. You do trials, you put hundreds of patients, if possible, into studies, and you say, let's try to compare this to this. What is really a standard of care now is almost like a sandwich of using chemotherapy and then surgery and then more chemotherapy. Now that's being reevaluated, and they're considering changing sort of the timing, maybe doing more chemotherapy first, et cetera, et cetera. But the bottom line is sort of like with pancreas cancer, chemotherapy is an important part of this, but to fully treat it, you need a surgery. Radiation plays a role in gastric cancer, even though it's a smaller role. You get other types of cancers, for example, the esophagus, where you always use radiation essentially, or most of the time. For the stomach, it's not as standard, but there are some situations in which it's being used, and it is being evaluated within the protocol, right? What if we were to use it here instead of there? What if we use it earlier instead of later, et cetera?
All right. So we've learned about pancreatic cancer. We've learned a little bit about gastric cancer. I think the take-home message is, see your doctor. If you have complaints, begin a workup. What I've heard, endoscopy is good for gastric cancer. Maybe a CAT scan if you're having abdominal pains to make sure you don't have anything in your pancreas.
Right.
And obviously, if you have any first-degree relatives, I'm understanding both gastric as well as pancreatic cancer, there's a relationship there.
Absolutely.
Right. And then, of course, if you have pancreatic cysts, if there's a doubt, we have the docs at Miami Cancer Institute. We have the hepatobiliary surgeons, the guys that deal with the liver, the pancreas, the bile ducts, and Dr. Asbun with his dad as well. His dad has probably less hair than you have.
Maybe a little less.
No, but these are two great guys that obviously I've known for years, and take care of all my patients that have these problems, my family members as well, and so forth. So, Domenech, thank you. Thank you for educating us. Any words of wisdom or advice for our audience that you would say?
Two things I'll mention quickly. One, our discussion around these cancers is always somewhat grim, right? But there is hope. There are patients that get cured, and even if you're not cured, there are a lot of benefits that you can get from treatment. So there is hope. This is what we do. Our treatments are getting better and better. And if anyone ever has any questions, our doors are open, or they should go see anyone, because there are things that we can do, and there is hope. And the other thing is I want to send a thank you to all the people that have gone through these diseases, because as surgeons, it's difficult to treat, and we have difficulties. The surgeries are hard. The complications are difficult to manage. But no one goes through it like the patients, right? And they and their family members are really the true heroes, and the ones that put up with this, and the ones that I can tell you personally give us a reason, give me a reason to work. And it's an incredible privilege to be dealing with this group of people. And so thank you to you guys.
Yeah, and I think thank you to those that participate in the studies and the research.
Right.
Like you talked about how it helps us. You know, I do a lot of research. You guys do a lot of research, and you know, it helps improve. Maybe it may or may not improve your care as a patient, but it'll improve the next generation's care because we've learned a lot with all the studies and the research. So I encourage patients to obviously seek help, seek attention, get experts to help you, but also if there's an opportunity to be involved in a trial, that's called a trial, a research trial, participate. It may help you, and more importantly, it'll help others. So Domenech, thank you for being here.
You're welcome.
Thank you for educating us again about pancreatic cancer as well as a little bit about gastric cancer. And once again, reminding you to take care of yourself and your family. Be well. Dr. Anthony Gonzalez with Miami Community